So, good morning, dear colleagues. It's a pleasure to be here with you. Thank you for coming over. I have the pleasure to introduce you to this joint symposium of the ESCRS and the Asia Pacific Academy. I'm here with sharing together with Rohit Parkash as well as Marie-José Tassignon. We are talking about posterior capsular tears, how to avoid and how to rescue. And the first speaker will be Professor Tassignon from Belgium, how to recognize the risk for posterior capsular tear intraoperatively.
Thank you very much for this kind invitation of the Asian Pacific Academy of Ophthalmology to invite the ESCRS to have a session here. I would like to, okay, thank you. I will need to have a little introduction, and in fact my introduction is also based on the fact that I have an intellectual property on the back in the lens, and by using the back in the lens I have of course observed quite a lot of very peculiar signs that are very interesting for the surgeons, even if they do not use the back in the lens, but if they do perform a posterior capsulorhexis. Indeed, the back in the lens is a lens that uses a posterior capsulorhexis, but by doing that, I understood a little bit better about the mechanics regarding the interface behind the posterior capsule. And that is really not a black box. It should be something that everybody should know about, because it plays an enormous role in for example, of course, in the PCO, but also in accommodation. And that we will learn much more about it later. Now, a little bit of introduction. To perform the back in the lens, you need to have a sized anterior capsulorhexis, and here I'm together with Thomas Nohan, who was one of the inventors of the capsulorhexis, the continuous capsulorhexis, and what I added to that is to make it sized with one of the techniques that are used to size an anterior capsulorhexis. There are many, of course. Now, it is also the only lens that can be positioned where you, as surgeon, would like to do it. And it will be of utmost importance once that the back in the lens will become EDOF, because you need to correct for angle kappa. You need to have a centration that is absolutely perfect in order to improve the quality of the vision of our patients. Now, I have to make a tribute to Jan Worst, who is one of my big mentors and who is one of the persons who in fact supported me in that journey in the back in the lens, because he learned me that the space of Berger, that is the white area in the middle of the image, that is not really small and really a quite large space that we can use, and that is very important also. The attachment, in fact, of the Berger space to the posterior capsule was described by Berger in 1887, but he's not the inventor of that ligament that will attach the anterior hyaloid to the posterior capsule. It is Germain Wieger. Berger wrote his book in 1887, and Germain Wieger did his PhD in the same city where Berger was also professor, namely in Strasbourg in Germany at that time. Germain Wieger described that ligament of Wieger, and he found out, and I will tell you why, that it is really a very important ligament. It is in fact a meshwork in order to avoid cells to pass through and to come behind the posterior capsule. Now we know now better that that area is quite large, 8 to 9 millimeter, so that is an area that is really useful and can be, for example, used for optic capture. When you put an optic capture, that lens, and you save the anterior hyaloid, that lens will be absolutely very perfectly positioned, or of course you use the back in the lens the same. When you perform a posterior capsulorhexis, and I think that this is quite important to know, you never fill the capsular bag, never. This is of course also not the most physiological condition to perform a PCCC. So never fill the capsular bag, point one. Point two, you do a puncture, lateral dragging the posterior capsule in order not to touch the anterior hyaloid, which is in most of the cases very closely located to the posterior capsule. So you drag laterally, inject immediately viscoelastic in order to push back the anterior hyaloid, and then you are in the safe side and you can perform your posterior capsulorhexis without having to fear to touch or to damage the anterior hyaloid at all. Now here you see it live, and here you see it in a young patient, dragging the posterior capsule, injecting viscoelastic, and look at the cushion that is formed, and suddenly the rim periphery will stop, because that is the ligament of Uyghur. It stops there. And that is absolutely important to know. You see that in your surgery. You don't need the OCT. Of course, thanks to the OCT, for me, it was more evident to show it to everybody that that ligament is really there, and that we can observe that by using the OCT. It was also possible for me to show that when I insert the back in the lens and that the two capsules, anterior and posterior capsules, are inserted in the lens groove, that indeed it is present there, and that we have two blades present in the periphery of the capsule bag. So little sidewards positioning, gliding the posterior capsule behind gliding the posterior haptic behind the posterior capsule, sliding it little by little, and then we can position the lens. I'm very happy that Orolab is now going to make that lens here for India, and I hope next year in Hong Kong we can make a wet lab on that technique. Now, one other person I would like to make tribute on is Emmanuel Rosen, and he's the first who clinically described an anterior vitreous detachment, which means that the ligament of Uyghur is detached from the posterior capsule. And we were the first to show that on the OCT, and not the first, in fact, Booker Dick was the first on the femtosecond. We were the first on the dynamic one, on the microscope, and where we could observe that there is indeed a detachment. When you follow the green, this is the anterior hyaloid. When you follow the red, this is the posterior capsule. And we look at the blue line, this is the anterior capsule. So the green and the red do not match or do not reach each other anymore. That means that you have a detachment. Now, what does it mean to have a detachment? It is quite important. For example, here it is a patient who has lots of dots. You do not know when you look at the slit lamp where it is located. On the OCT, you see that the Berger space is full of dots. And it can only be explained because there is a detachment. And you see it here on the OCT, the line, the white line behind the posterior capsule that is bulging, that straight line is the anterior hyaloid. And there you have lots of dots. That anterior hyaloid is far away from the posterior capsule, explaining why you have dots. Because normally the Uyghur ligament as a meshwork will prohibit cells to pass through that meshwork. Now, which are other signs that we found? This is a patient with a PEX, and this is when you do the irrigation aspiration and you snap easily the posterior capsule in your irrigation aspiration probe, that means that you have no support of your capsular bag, of your posterior capsule anymore. And that is due to the fact that there is a detachment. So you know in these cases that you have a detachment, of course. Now, we did a study to look at the OCT when the detachment do occur. And it's strange enough, it occurs from 45 years on, and it is almost present in 60 to 70% starting from 60 years on. That means that it is just like we have a PVD, we have an AVD. Whether that is similar and simultaneously occurring, we do not know yet. Now here you see little fragments of the lens. How can you explain little fragments of the lens in an intact capsule? That means that they went through the zonules, and you can only explain that they went through the zonules if you have a complete detachment of your anterior hyaloid. The ligament of Uyghur is one attachment area, but of course also the anterior hyaloid is attached to the hyaloidal zonule at the periphery, and that is also loose, otherwise you have no fragments there. So in these cases, you know that you have a very fragile, or you have the chance, no support of the capsular bag anymore by the vitreous. Now, when you perform a posterior capsulorhexis and you inject OVD, you have the spaghetti-like distribution of the OVD. This means that you really have a huge, huge space. And if you have a huge space, you almost can fill the whole syringe, which is not a problem if you inject viscoelastic, because the lens is 4 millimeter in thickness, and you will replace it by 1 millimeter, so you have space enough to leave that OVD there. Now, Mittendorf dot was wrongly described by Mittendorf that it is an attachment at the posterior capsule. It is not. It is attached at the anterior hyaloid. And this is very beautifully seen also on the OCT. So when you see a dot, a Mittendorf dot, that means that there is your anterior hyaloid. In pigment dispersion syndrome, you will see the deposits of the pigment in the angle between the ligament of Wieger and the zonular area. If you see them floating behind your posterior capsule, that means that it is the shy line is detached and the ligament of Wieger is hanging there together with the pigment. And that is not so rare that you can see that. So all signs that you have to pay attention that these are very fragile capsules, very mobile capsules, so the risk for your trainees to damage the posterior capsule is very important. I would like to remind you, and you are heartily invited to attend the Copenhagen ESCRS edition in September this year. Thank you very much for your attention.
Yeah, thank you so much. It was very instructive. I think in the interest of time, we keep on and then discuss all the aspects, if you agree. So the next speaker will be Rohit Parkash, and he will show us different case scenarios of posterior capsule rupture, strategies for optimal outcomes.
Thank you, Dick and Mary, for this opportunity. So I would be taking up different case scenarios of posterior capsule rupture, strategies for optimal outcomes. Well, we have to realize that anterior vitreous phase and posterior capsule rupture, as Mary has just shown, they are two different things. So what I would like to state is that if the fluid parameters are high, even with an intact capsule, we can end up with anterior vitreous phase rupture. So turbulence is another one thing which is something which can cause posterior capsule rupture and anterior hyaloid phase rupture and eventually lead on to a nucleus drop-like situation. So AC fluctuations are also very important. So you need to have stable chamber settings by all means so that you don't rupture the anterior hyaloid phase and eventually cause catastrophes. So this is another scenario wherein you have to create stable chamber settings. So you should not allow the posterior capsule and the anterior hyaloid phase to come suddenly forward and cause rupture. So that is another very important factor. So what are the different things which make anterior hyaloid phase friendly? So the settings which have to be used is that the first thing which you have to bear in mind is that you have to have proper scanning whether there is any pre-existing posterior capsule rupture. The second thing is that you have to have calibrated incisions by which you should have stable chamber settings. You should have active fluidics, no financial interest whatsoever, and slow motion phacoemulsification, as has been shown by Bob Osher, because that creates a situation wherein there is a minimal pressure difference between the anterior and posterior segment. So let's take this case, which is a patient who has a fibrotic cataract. In this patient, the case details are that there is no doubt the right eye has a fibrotic cataract. The left eye slit lamp examination shows that it is pseudophakic with optic capture. So this shows by any means it would have been a case wherein there was a posterior capsule rupture. So what my plan is that no doubt I would be using flax to my advantage, but I would be cautious of PCR because there can be a situation wherein we can have a posterior capsule rupture pre-existing. So let's see how we move around. So flax in fibrotic white cataracts help because it's a closed chamber. The capsule cuts over the fibrotic bands. Increased laser energy and increased incision depth helps to cut the fibrotic bands. So in this video, I'm doing the tripod-induced staining, the 30 gauge, which is my favorite technique, which we published. Luckily, 80% of the fibrotic anterior capsule had been cut with the maneuvers, which I've already shown. I'm trying to peel it off, but I realized that it would have put stress to the zonules, so I'm just cutting it with the scissors, and now I'm able to complete the rhexis. So one thing done, now I'm doing, creating a small gutter in the center, then I'm going to chop it. I'm going to use, a pointed chopper and separate it at different planes, lateral separation as has been shown by Vasavra et al. Then I'm going to rotate it. So I'll be cautious to rotate it not very, violently. So I'm going to chop it again because the funda is to have two total separated nuclear fragments. And the moment I separate it, I realize you will find that there's a PCR. So this is a situation in which the whole nucleus is in front and I have a PCR. So what is the game plan now? The game plan is to use anterior hyaloid phase friendly settings. There should not be any rotation. I would use IOL as a scaffold, do supracapsular emulsification, or do optic capture if possible. So this is how I'm moving around. So now I'm going to pull it up. Mind it, my fluidics are at 20. So I'm going to chop it now. I have brought it slightly forward. So here I'm going to use a trick. At this point of time, there is no overinflation of anterior in the anterior chamber. I'm going to use nuclear fragment as a scaffold. So I've placed it slightly over it. And then now I'm going to pull it out. With the low infusion at 20 IOP, the posterior capsule is not being pushed behind. The chance of anterior hyaloid phase being ruptured is little, as has been advocated by Vasavra et al. In different present in publications. Now the problem is that it is subincisional and we have the full posterior capsule rent in it. So I'm going to go slowly. You would find that it is not over deep. So the trick is you move slowly and slightly anteriorly. The idea is to go right across the rent, and the moment you do it, that is the time when I'm going to pull it out. So with this, this is possible because of the the IOP settings of 20, flow rate of 26, and everything is being used. Now enough is enough. Now what I'm going to do is I'm going to use IOL as a scaffold to prevent posterior migration of the nuclear fragments, because at this point of time, with the nuclear fragments getting smaller, it would be difficult for for me to keep the nuclear fragments ahead. So I'm going to use stable chamber settings again. I'm not going to allow the anterior hyaloid phase to come forward, and with stable chamber settings, now I'm going to use IOL as a scaffold, as has been advocated by Amar Agarwal et al. With this, I'm able to work at a deeper plane. So I am now going to go right near the IOL, away from the anterior, from the cornea. And now I'm going to do optic capture, triamcinolone, to show that there is absence of vitreous whatsoever in this patient. This is another patient who has had an anti-VEGF injection, trauma-induced cataract. So it's a fast progressing cataract. Visual acuity after increasing has decreased to finger counting. The anterior segment OCT shows that there is a posterior capsular rent. So now what I have done is I have used flax to my advantage. The IOP settings, this is a calibrated side port incision which calibrates to the chopper which I use so that there is no efflux, undue efflux from the side port. After doing the taking out the anterior capsule, the IOP has been further brought down to around 20. I am doing sculpting. My concept, I have already done femto delineation in this patient. So once that is done, now I'm trying to separate it fully without using wide separational forces. Now I'm going to take out the outer nucleus, leaving behind a femto delineated epinucleus. I'm going to, since it's a soft cataract, I'm going to use it supracapsular, and mind it, the fluidics are at 20 IOP. So the anterior hyaloid phase again is being subjected to anterior hyaloid phase friendly settings. So with this, I'm moving around stable chamber settings. See the calibrated side potency and stable chamber settings, which I have used to my advantage. Now, what I'm going to do is I'm going to remove the epinucleus. Oh, sorry. So what next? So epinucleus with posterior placed open posterior capsule has to be taken out. I'm going to continue with the physiological setting. Separate planes for irrigation and aspiration. Use triamcinolone, dry aspiration, and do IOL implantation. So here we go. I have retracted the sleeve. IOP is 20. So the posterior capsule, which was not exposed till this time, is going to be exposed with normal, IOP settings, with anterior hyaloid phase, friendly settings. So this is going to continue. I'm going to take it out slowly and, in a very, because at low settings, at times you have some, with this, now I'm doing the stuffing of the cortex of the epinucleus. The surgery is almost done, and I would be implanting the IOL using triamcinolone to show the absence of, the vitreous in the anterior chamber. So this is another posterior polar cataract with pre-existing defect. So in this patient, what I'm going to do is, this is another scenario where I know that the posterior polar cataract has a pre-existing defect, a small opening. I'm going to create an oval rhexis to my advantage, because this gives the advantage of both, as has been shown by Dr. Kiranjit Singh, the advantage of both a small and a large rhexis. Once that is done, there's not going to be any hydro procedure whatsoever. IOP settings at this point of time are 34, because this is a very slightly old video. So I'm going to do separation. Once I have done the separation, I'm going to do cross-chopping, as has been shown by Ron Yaw, and so that I'm not rotating the nucleus. So now that is out. The next step would be, I would be, doing, I would be taking out this nuclear fragment after totally separating it by doing a backward flip. So this flip with the IOP now reduced to around 20. So once that is done, I'll move on. So now comes the most interesting thing which I want you to see after I emulsify this nuclear fragment, how I'm using everything to my advantage. With this, I'm pulling it out. So now what I'm going to do is, I'm going to zoom it. When I'm going to zoom it, I'm going to show you how the nuclear fragments, they do not go behind. They bounce on the anterior hyaloid phase and they come back. Look at these three nuclear fragments. They will not go behind. It's a very, an environment, an AC environment, which is non-turbulent. So, and it is not being pushed behind. The nuclear fragments just continue to focus on these three nuclear fragments, and you will find that they are going, they are bouncing, and then they are coming back. So this is a condition wherein, even with a posterior capsule rupture, it shows that with an anterior hyaloid phase intact, you can create a situation where the anterior hyaloid phase doesn't get broken whatsoever. You will see that these nuclear fragments continue to bounce. They don't go behind whatsoever. So now at the end, I'm going to use stable chamber settings, because the whole work would have been undone had I just, made the anterior chamber go shallow. So the last thing which I'm going to do is, I'm going to do, I'm going to visco express, if I can, one or two, these two small nuclear fragments. One of them has come out, so two remain. Now, so I'll be doing the dry aspiration, as has been taught by Bob Welch and James P. Gills. So once that is done, I will implant an intraocular lens. So this is what it is. Now the intraocular lens is going in, and you will find, I just want to show one thing, that how it is, the last nuclear fragment would come out. So this is how, we can we can involve definite strategy, appropriate with appropriate fluidics, and respect the anterior hyaloid phase, and have friendly outcomes. Thank you so very much for your kind attention.
Thank you so much for these beautiful videos, sessions. And now I would like to invite Booker Dick to speak about anterior pars plana approach.
Yeah, thank you so much for the invitation. It's a pleasure to be here with you. Can you bring up my slides, please, my presentation? There we go. So I'm talking about pars plana vitrectomy and from the anterior surgeons. And the goal, of course, as you all know, for vitrectomy is to avoid intraoperative traction and don't risk it all for sinking lens fragments, please. Also, what you want is adequate vitreous removal, prevent a further enlargement of the posterior capsule rupture, and need a symmetric uniform support for the IOL, and the approach could be limbal or pars plana. As you have seen already, the staining is an issue. Rinse off preservative triamcinolone or use preservative-free, and dilute either 5:1, for example. And my personal advice is adjust your cut rate. I personally prefer a B-blade cutter. For high cut rates, use for vitreous, for example, 2,000 cuts, and use low cut rates for lens removal or OVD. I'm going to address that later. And also fluidics are important. What I also advise you is close the ear chamber and separate the irrigation from the aspiration or the cutter, and aspirate and cut posteriorly, irrigate anteriorly, and take down the bottle as low as possible. And then we have these two approaches. One approach is the limbal approach. The pros are, well, it's well within a cataract surgeon's comfort zone, and it's a firmly established routine practice. The cons are, as you have seen on the right of the video already, it triggers intraoperative vitreal retinal traction, and often the tears enlarge after limbal vitrectomy, and also, for example, in the back IOL fixation may no longer be feasible. The pars plana approach, in contrast, comes along with minimal vitreal retinal traction and reduced risk for posterior segment issues, and the posterior capsule tear enlargement is minimized, so allows for thorough and controlled vitrectomy. The cons, of course, are it's uncharted territory for many cataract surgeons and perceived as complex and intimidating. And the questions, of course, and I will address this now, it requires advanced setups and specialized technology. Is this true? Well, let's talk about pars plana vitrectomy approach now. So I will not talk about limbal. So we have to talk about trocars and sizes and settings. So my steps for success come with 10 steps. First is recognition of vitreous. Once you see the vitreous, you stop phacoemulsification immediately. Don't go behind the lens into the vitreous and do phaco in the vitreous space. Next is clear the clear corneal incisions of vitreous and secure them. Maybe you want to hydrate them. And also provide sufficient IOP for these eyes using OVD or irrigation, for example, as for example, Agarwal provides, suggests anterior chamber maintainer, and you need a single port trocar, and that is commercially available. So it's sterile, and you can buy a single trocar. You don't need the full set, only the single trocar. And what I prefer, this is just the starting of a surgery, a pressure plate and a direct trocar insertion, as you have seen. Then you will decide whether you go for 23 or 25G. So 23 if the epinucleus or cortex remnants are still present. 25 if it's only vitreous, so the posterior capsule came quite late in the cataract procedure. And also, if you are doing topical anesthesia, only drops, my recommendation would be that you perform a scleral perforation first, using, for example, these very sharp MVR blades. And if you are doing retrobulbar or peribulbar, sometimes we don't even know where we are exactly, my recommendation is a two-step sclerotomy. And then you introduce the trocar transconjunctivally, 3 to 3.5 millimeter pars plana. Of course, it depends on the problem location. It does not necessarily need to be temporarily, but because often most of our surgeons are right-handed. It's located temporally. Here you see these MVR blades, which I really recommend because you can do it under topical anesthesia and the patients will not feel it. Yeah? So here you see it's way sharper than the trocar. That's the big difference. The trocar is sharp, but it's not sharp enough to do it in a case. Here you see the posterior rupture. This is, as you have seen, a topical case. Therefore, if you have small eyes, you use this gauge, and then you just go in, and that's it. Then introduction of the trocar is quite easy. It's not advancing. There we go. I'm not sure why it's not. So we cannot play this media, sorry. So next is, I also suggest a trocar with a valve. Yeah, on the right hand, you see they're also commercially available without valves. The reason why with valve is you will always have a controlled IOP and never an egress of fluid through this opening. Yeah, so an egress means the IOP goes down below low, or at least it will be zero, and that is a big difference. And also the ninth step, so to say, is that you introduce then the high-speed cutter and do the partial core vitrectomy. It's different from anterior. And also what I recommend is decrease the cut rate for the residual cortex and epinucleus removal, because with 23 then you can easily take it out. And I prefer a dual linear foot pedal. Why? The conventional is just a fix, cut and aspirate and that's it. That means that you often enlarge the posterior opening more than it is needed. But with the dual linear, you can separate the vacuum and the cut. And you can preset that once you have an increased vacuum, you come with smaller cut rates. That means it's way easier, and you don't need to change the settings in your device. It's already preset with the dual linear foot pedal. So it's a real-time adjustment without thinking. You just do what you think is right, and the machine and yourself will be on the right place. And then you remove the trocar and exert some external pressure, and that's it. Here you see the removal of the trocar. You just take it out. You see the patient was still under topical anesthesia, and then with the sponge you just wipe the conjunctiva and it's covered. So these are the steps for success. And interesting, there's literature, and we have to talk about that, posterior approach is better than anterior. So this study, for example, included 340 eyes with anterior posterior capsule rupture and using anterior vitrectomy. And when compared to historical data for limbal vitrectomy approaches, this large case series demonstrated that the pars plana approach resulted in lower incidence of postoperative retinal detachment, cystoid macular edema, IOL instability, and endophthalmitis. So here you see the case again. So what you do is, in this case, this is a late rupture. You keep the irrigation in the eye, give some pressure into the eye using OVD, and then in this case, I decided, because I saw there's only one fraction, that means only one rupture, and that means that you can then easily inject OVD, push back the vitreous, which is not in the AC. You don't need, in this case, a triamcinolone or something like that. But if you are in doubt, always use it, please. So then I just grasping the OVD. That means we described that in the book that's available in the Springer that you can use and see all the techniques are described by us in the book on use of OVD. And then with a microforceps and grasping, a Koch microforceps, I'm just performing a round tear, so there will never be the possibility that it widens or opens. You just grasp it, and here I take the other side, and then you have a round edge posterior rupture. So, and now I go to the back, because you can also go now, of course, anteriorly, because you have a round opening. But just now I'm going to show you how it is done posterior. There you see it. It's very sharp, these MVR blades, yeah. And then you introduce it a little bit, and irrigation. And now with a separate dual linear foot pedal, I come from the back and do my anterior vitrectomy. In this case, of course, you can implant the lens into the back. You use an one-piece hydrophobic acrylic IOL, and it's then implanted into the back. Gonna forward here, maybe here, and here you see the lens is already in the back. OVD is taken out, and that's it. So in the interest of time, I'm gonna skip that case, but there are many things to think about. The take-home messages will be the monoport vitrectomy as I introduced to you is effective, safe, and comes with less vitreoretinal traction and complications. And then IOL fixation in the back, in most cases, I would say, is possible. And I recommend this adequate surgical technique. By the way, if you are doing this, you are opening your spectrum of potential treatments. And that is a capsulectomy and a primary fibrosis. Many other, as you can see here, for example, phacoemorphic glaucoma, vitreotraps for diagnostic purposes, and membranes in disabled patients, vitreous aqueous misdirection syndrome, or for example, if you want to fixate sclerally IOLs, then you're better off with it. My personal general recommendation as a vitreoretinal surgeon, I can tell you, whatever the approach, ensure adequate vitrectomy before proceeding to the next step. Don't go all in, please. Thank you so much, and you're cordially invited to Copenhagen. Hope to see you there. Thanks a lot for your attention.
Thank you. Oh, yes, we will discuss everything at the end. And now it is my pleasure to introduce Dr. Vladimir Pfeiffer, who will speak about how to do when there is not enough capsular bag support.
Thank you, Marie-José. So, at the beginning, I want to say some things about, say, phaco. So, the most important phase of phaco, I think, is capsulorhexis. And in my hands, the most safe capsulorhexis is done with the forceps, and we start in the center. So, how to do the phaco? The safest in my hand is quick chop or vertical chop. And when eliminating the material out of the anterior chamber, we have to have the phaco tip still in the center of the eye, somewhere in the iris plane or a little bit higher, and we don't move it. My residents, dare not move the phaco tip. Everything is done with the second instrument. All the material is brought in front of the phaco tip with the second instrument, with the other hand. In this case, there is very little chance to get the capsule or to catch the capsules. And the last day part, we take a little vacuum and we hold the chopper deeper than the phaco tip. So what about irrigation aspirations? I would never do that, because if we inadvertently get the capsule, catch the capsule and pull, we have a tear. So what I'd advise to my younger colleagues is to go to the material, don't move the irrigation aspiration tip, and just aspirate, just play with the foot pedal. You can have vacuum as much as you want. And if you catch the capsule, and if you don't move the phaco tip, the irrigation aspiration tip, nothing will happen. You can go up 250, 300 millimeters. You won't have a tear. You can hold the capsule. But if you pull, you have a tear. And you have to look if the opening at the IA tip is nice, if there are no sharp changes. So polishing left to right with a big olive polisher. So things happen, and here we have a opening of the posterior capsule. So the best things, what I advise is stop infusion. Leave the phaco tip in and inject the viscoelastic, whatever is there at your hand. And then you have a stable situation, denting, and now we have changed the surgeon. So the first thing is to inject the dispersive viscoelastic to separate the vitreous. Then you have anterior chamber without the vitreous, and you can slowly, with low vacuum, low phaco, with dual linear control, emulsify the hard parts of the nucleus. You have to check for the vitreous. You have to use triamcinolone is needed, but you have to re-inject the viscoat as much as you need to make the barrier between the posterior and anterior part of the eye like a scaffold, like an IOL, but in this case, viscoat is enough to have two separate places, and you see there is no turbulence behind the capsule. So then, when there are smaller pieces, I enlarge the 3 millimeters because I'm going to use a 3 millimeter lens, 3-piece lens, and I just visco eject, as you have seen that before. If some parts are needed, you can aspirate them with a vitreous probe. And look, I never had infusion in this part of the surgery. I'm injecting viscoelastic, I'm aspirating. And now expression of the last hard pieces of the nucleus. And now I've changed already to methylcellulose, because methylcellulose can be aspirated. And you have all the time, and this is dry aspiration, you have all the time a safe place and vitreous behind you, and you can aspirate as much material as you wish. If the pressure in the eye gets less, you just inject the viscoelastic, the methylcellulose. And then we make a space between the posterior capsule, anterior capsulorhexis, and the iris, and we inject the lens and implant the lens into the sulcus. If the capsulorhexis is small enough, the best thing is do the optic capture, but here in this case, the capsulorhexis was very big, so I just left the IOL in the sulcus. But optic capture for sure is a better thing. And in this way, if we have a barrier between the vitreous and the anterior chamber, we can perform very slow phaco. So what if we don't have, if we have a loose zonules, you see, they're very loose. We even cannot make a capsulorhexis with the forceps, so we need a needle. In this case, I did a little bit bigger capsulorhexis, ejected the lens out of the back, did a phaco in the anterior chamber. I even didn't need a iris hook until this moment, and now I'm just aspirating the rest of the cortex and implanted the capsular retention ring. I wasn't sure if I would need to suture it, so I used the Ciani ring. And after releasing the ring into shooting the ring into the back, the 3-piece IOL was implanted. And we, at the end, didn't need the suturing of the capsular retention ring. So the first haptics goes into the capsular bag, and then the lens is dialed with the second haptic into the bag. Released. and then the lens is properly oriented. In some cases, there is too huge zonal lysis. We see this on this page. This patient, here was infusion, and I thought maybe I could do it with the capsular tangerine, but it was not good decision. So when I implanted the IOL, the infusion was on, and the IOL went back through the iridodialysis. So the lens had to be brought back into the anterior chamber, rotated. We can push it backwards and rotate. And now I've decided I'm going to go for scleral fixation. I should have done that from the beginning. So the one haptic is taken out of the eye. The ring and the capsule is explanted. We can just pull it out. And then the suture is cut, the Prolin suture 60, which we use to stabilize the capsular tension ring. And now I'm doing the Yamana technique, 2 millimeters behind the limbus, 30 gauge needle is being, tunnel is being done, and this needle is docked. The haptic is docked into the needle at one side. It is put onto the iris, and now the second haptic is taken about 2.5 millimeters from the edge and put into the needle. So this is a minimal invasive sutureless technique, which I used from 2015 and has very good results. So now both needles are pulled out simultaneously, and we release the left needle, we take off the right needle, do the flange, then do the flange on the other side, and both flanges or haptics are pushed backwards into the sclera. And this is the case at the end. So, very nice outcome. I will have to take care of the iris next time. So in cases like this, ectopic lens, this is a child, 6 years old. I go for scalar fixation from the beginning. Small capsulorhexis was done. We are irrigating with methyl cellulose and aspirating the lens out of the back. The back is then taken out of the eye. And now the scleral IOL fixation is performed. In children, we go 2.3 millimeters behind the limbus because we could have a optic capture. And the same is done on the other side. The needle, the haptic is docked into the needle. And then both haptics are pulled out. So it's 30 gauge needle. It's a sensor IOL. There are other lenses that are also very good for this technique. So the left is released. On the right side, the flange is done. Then on the left side, the flange is done. And the haptics are pushed backwards. And this is the case at the end of the surgery. So I think the best way is the scleral fixation. I'm using both two of those from 2015 and 2018, and they really made my life a lot easier. So we should think before we start the surgery, not at the time when something happens. Thank you very much.
Excellent talk. Thank you so much, Vladimir. Really enjoyed all the surgical pearls. Next speaker will be Professor Kronen from Germany, Frankfurt. on IOL implantation, explantation, and or re-implantation with a broken or open posterior capsule. Thomas, please.
Thank you, Burkhard, for the nice introduction. Thanks the APAO for putting this together, and of course the ESCRS for supporting our come over here to Asia. Let's go to the slides. Okay, if we talk about capsule rupture and all the topics we had, let's look quickly at the incidence of capsule rupture. When we change from can opener technique to capsulorhexis, Marie Tassignon showed you nicely Thomas Neuharn's picture when he performed capsulorhexis. In the early days, there was a reduction by 100%, 8.4 in the early phaco times to approximately 4.5%. If you look at the literature nowadays, let me try to give forward here. They don't move forward. Can you put the next slide? Okay. So there's a study from Malaysia, and that gives you basically a rate capsule rupture in these number of 3.2% in overall the numbers. Can somebody advance the slide? I cannot go forward. Just don't. Okay, go over here. Maybe better here. Okay, good. Thank you. Thank you. I do it this way. Okay, this 3.2%. If you look at the literature, you also found, series. This is a paper published in the German literature, actually my brother, and he found his weight of 0.34%. So it really depends on surgeon, I think, where we have the number of capsular ruptures. They also have to understand that if we perform a super good capsulotomy, for example, with a femtosecond laser, that it may be an indication. And there was a rumor that femtosecond laser actually has more capsule rupture posterior, and that's actually not true. If you look at the literature, you found the same amount of 0.31 to 3.5%. In general, I would say nowadays a good surgeon has a capsule rupture rate of 0.5%, so 1 out of 200. Now, implantation, explantation, and reimplantation. Here is the normal way out. What we have in capsule rupture is if we still have a sulcus, we can put the lens into the sulcus as a normal preferred procedure where we don't have to do any of the other techniques. So capsulotomy is key, capsulorhexis is key. If you maintain the capsulotomy and you have an anterior scaffold, you always can put the sulcus lens in. And that's published in the literature showing here sulcus IOL, how they perform. We always have to think about IOL calculation. That's important. In terms of posterior ruptures, you have seen a lot of my colleagues showing this. One problem here I'm highlighting is if you have a rupture and you already had a premium IOL, let's say a trifocal IOL in the first eye, you want to achieve that implantation in the second eye. So what you do is here is unfortunately not a round opening. It's an opening in the posterior capsule where you still have some scaffold, let's say posterior parts of the capsule to put the lens in. This was done. Sometimes it doesn't happen right away. He had problems with putting the lens in the capsule bag and had to do it a second time. But eventually, with this approach, I was able to put the lens into the capsular bag and got a good outcome. As shown previously, you have to do usually vitrectomy because you have residual cortex or vitreous, particular vitreous, in the anterior chamber, and you have to deal with this. This is the second approach. I had to put the lens haptic second time in the capsular bag to make sure that this lens is centered. Optic capture is also an option when you have, the implantation. You can do it in the sulcus, and you can prolong the optic posteriorly. You can also put the lens in the capsular bag and put an anterior or posterior optic capture. Posterior, for example, in children. Anterior when you still have an anterior approach. And that's important. We have talked about all these techniques, and I really quickly go through them because I want at the end to make one important point for our IM and explantation. Chariot was one of the first with Agrawal to put the sclerofixated IOLs with no capsule. We have also in Europe at least available the Artisan as a retropapillary Artisan. You can see this here. After we have explanted a lens, that can also be done in a cataract procedure where you have a huge capsulotomy and a capsule rupture. We put the lens in here as an easy procedure. You bring the lens behind in a way that you actually turn around the lens, and then you put the Artisan onto the iris, or the iris into the IOL, and that gives you at the end, if you can see here, a round, nice result with a posterior chamber, so to say, IOL situation. You have seen the Yamane technique. It's a preferred technique nowadays because our advantage in comparison to the Artisan lenses is actually that we have a small incision, and we can even take out lenses through a 2.5 millimeter incision and then put the lens as a foldable technology into the anterior chamber and implant the lens when you have no capsular support for any other type of lens. So you have seen the Yamane technique, and Kalevala is also something what gives you opportunity to implant a lens with no capsule support, particularly in those lenses who need maybe high astigmatic correction. Options for IOL explantation, this is a topic. Of course, you always can enlarge the incision, make a large opening and take out the lens. But of course, our desire is to keep the incision small. We can use tweezers, we can use cartridges to remove the lens, or we actually cut the lens into pieces. This here, for example, is an explantation with tweezers. You can basically remove this hydrophilic lens. In total, your incision might be around 3 millimeters. You can see here how I remove the lens. In total, this is due to an opacification of the intraocular lens, and the lens has to be taken out. We always want to be very careful to maintain the capsular bag, because if you maintain the capsular bag, you later can implant the lens. This is a situation where you have actually some damage to the IOL optic, and therefore we decided to take out the lens. This with a 33 diopter, so a very thick lens, so you need a really sharp and a very strong scissor. In this regard, we really cut the lens into 2 pieces in order to make sure that you can take the lens out. That sometimes requires some force. Here you can see also the haptic has broken, but basically you move around the lens. It was, again, 33 diopters, so a very thick lens. You move around the lens. Here's a foldable trifocal lens, and make 2 pieces out of it. So you only need a small zip here at the end. You require a second instrument which holds the lens. And here I'm using actually the technique of taking the haptic, holding it with the haptic. You also can take a microforceps through the paracentesis. And once you have done this, then you can remove the lens. This is a technique which has been a little bit subsidized, what I'm showing next. This is actually the end of the previous procedure, where then a lens is put in the capsular bag after this damaged IOL was taken out. Nowadays, we're using more and more the technique of taking just half of the lens out, so cut the lens only partially. So basically, here again, I'm using the scissors, a stronger scissors, particularly when you have diopters above 25 diopters in hyperopes. So here, we only partially cut the lens, and then we use the incision as a hypomochleon, and you can see here how we dial the lens out. You have to be careful that you don't incorporate or tackle the second part of the optic into the iris, but the lens is actually being removed here. This is also a procedure which you can use for IOL explantation when the lens is dislocated posteriorly or in the posterior chamber. Bring it up, and then you have foldable lenses with a capsular bag. You can take them out. So this is explantation technique. Requires a little bit, patience, but when you very carefully have the lens, take it out. So the cutting partially is also done here in a plate haptic design lens. You can, of course, make sure, as I pointed out, you have to hold the lens, and then here you cut lenses into pieces. Sometimes it's quite difficult with plate haptic design to take them out. This is, you don't want to leave any of the material inside, but basically you take it out and then you put the lens back. Coming to the last point, and that is the implantation. Here is a situation where actually an implant was done after removal of a lens. The lens was thought to be in the capsular bag, but the IOL actually dislocated into the posterior chamber in the vitreous. So the vitreous surgery has to be done. We had to remove this lens from the vitreous, bring it forward, and actually, because we consider not to be able to put that lens again, it's a trifocal lens, into the capsular bag because we're already losing it, we took out that lens here in a cutting mode again. We took out that lens and put this lens, the second lens, actually as a sulcus fixated IOL. Unfortunately, worldwide, we're really thinking, or we searching for these multifocal lenses which are sulcus fixated, and we do not have them. Let me end up with one important study I think we just recently did. Complications of IOL exchange after YAG capsulotomy. We did a retrospective evaluation of all eyes with IOL exchange, luxation or subluxation lens excluded. We had 37 eyes, 16 with prior YAG capsulotomy and 21 with intact posterior capsulotomy. Most common indications have been optical phenomena of these lenses, 18, and refractive errors were 7. And now we look at the complication. Complication we count here as anterior vitrectomy, because usually when you do an IOL exchange and you have a posterior capsule closed, it's easy to explant and implant a new lens. So here we had 50% of anterior vitrectomy with the open posterior capsule, only 9 in the closed, and exchange back-to-back was only done 70% in the open posterior capsule group, whereas we were able to do this 100% of time in these eyes where the posterior capsule was still closed. So significantly more difficult IOL exchange in eyes after YAG capsulotomy. Therefore, YAG capsulotomy only when IOL exchange is excluded. And I'm talking here specifically about premium multifocal lenses. Don't do YAG capsulotomy before you have actually decided that this lens stays in the eye. Summary, be prepared for an open posterior capsule all the time. Implantation techniques, there are multiple. Sulcus implantation, even in the bag, is possible. Optic capture is one option, retropapillary or any type of scleral fixation. Explantation is a delicate procedure. I think we will use it more and more, particularly when we use premium IOLs. Optical phenomena might force us to change the lens, and reimplantation is not always possible as planned. So take care of your YAG capsulotomy cases. Thank you again for your attention, and of course, we all invite you to come to Copenhagen in September. Thank you.
Excellent. Thank you very much, Thomas, for this beautiful presentation. And now we end this session with Amar Agarwal, and he will speak about the IOL scaffold.
Thank you very much for the entire ESCRS team which is on the dais, Mary, Vladimir, Burkhard, Thomas Conan, to invite me here for this presentation on the IOL scaffold technique. So we published this in the year 2012, and you can see in the animation, the lens nucleus is present there. There's a PC rupture. Bring it up anteriorly after vitrectomy. Now implant a 3-piece IOL. You can put one haptic above the iris, both haptics above the iris, but the idea you have created your own posterior capsule to emulsify that nucleus and put the lens into the sulcus if you have a good rhexis. So same thing on the surgical case, you see, I'm implanting that 3-piece IOL. One haptic is gone above, the other haptic is outside. Now I'm creating my own posterior capsule, bringing the lens to the center, emulsifying that, and before you can say bingo, that nucleus is gone. Now all you need to do is, in this case, I've got enough rhexis so I can dial the lens into the sulcus and I'm on track. Let's take the difficulty to the next level. Doing a phaco, you have a PC rupture, big rent. Now what happens is, fix a trocar AC maintainer. The advantage of trocar AC maintainer, the fluid is above the iris. Create your scleral flaps. Now I'm doing a vitrectomy. Once I've cleared up all this vitreous A's, I will then implant my IOL. I can do the posterior assisted levitation, bring the nucleus anteriorly. Once I have put that, emulsify that nucleus. Again, the scaffold works very comfortably. Use iris hooks. Now at this stage, now do the handshake technique and convert to a glued IOL if there is no capsular support worth the name. Take out the iris hooks and then see if your pupil is too large. You can also do at this time a 4th row pupiloplasty and close up this case. In this case, in this animation, you can see I'm showing the single pass 4th row pupiloplasty to make the pupil small, because in most of these cases, sometimes the pupil might be very mydriatic and dilated. So this is on the animation. Now let's see on the actual surgery of the patient, how the patient does, and we'll see the same thing as the IOL scaffold technique working. Here you can see the 4th row pupiloplasty completed and the pupil bang on track. Take out the trocar AC maintainer, apply the fibrin glue and seal everything down. Now see in this case, we started the phaco, got a PC rupture, look at the vitreous loss. The huge bulb of vitreous has come there, doing a vitrectomy, clearing it all off. Once that's done, now my main concern is I don't want that lens sinking down. This is the trocar AC maintainer. We first designed it with Mastel and published it in the year 2016. You can use the Alcon one. The blue color is the best, which I feel, because that's 25 gauge. You can use the orange color, which is 23 gauge. But the advantage of the 25 gauge, I think, is ideal size. Either way, whichever one you use a trocar AC maintainer, because it's above the iris. I made my flaps, made my sclerotomy now. Once I've done my sclerotomy, I'm going to do the PAL technique, which was started by Kelman, David Chang, Richard Peckard. Once I brought it up anteriorly, now what I'm going to do is, I'm going to then implant the IOL. Here you can see I'm doing a little bit of vitrectomy to clear up my visualization and this cortical area, which is cortex, which is present there. But the nucleus won't obviously come out with the vitrectomy probe. So take the 3-piece IOL. Always prefer to use the 3-piece IOL, because then you can glue it, put it into the sulcus, whichever one you want to do a Yamane, whatever technique you like. Once I have got this inside, I've placed one haptic above the iris. Now I'm placing the second haptic also above the iris. In the previous case, I showed you one haptic above and one haptic outside. Here I put both above. Now I'm very safe. I tend to use an air pump, so I've got a deep anterior chamber, which is gas-forced infusion, so the effect of the endothelium problem is not there. Once the nucleus is removed, then life becomes very easy, because to remove the cortex is not difficult. You can use the vitrectomy probe, remove all this cortex which is present there with the vitrectomy probe, because once the nucleus has come out, then the fear of the nucleus pieces falling down is not there. Then, as I showed you in the animation, now use the iris hooks, because now you don't mind the pupil becoming a bit larger. Now you can easily attack that areas of the cortex which are subincisional or even behind the iris, even if it's not subincisional, in 360 degrees around very comfortably. Bring the cortex or the epinuclear pieces above the IOL and you are completing this case. Here you can see the final portions of this area of cortex being removed. I'm using an iris spatula just to prevent me by accidentally chewing up the iris there. Once that's done, now see the handshake technique working. So I transfer haptics from one hand to the other, because my IOL is now above the iris. I need to bring it behind the iris. So once I have done that, I'll use the handshake technique, catch the tip of the haptic. Before I external, I'll clear up all this muck which is you're seeing there. Once everything is removed, the haptic comes out. If you want a Yamane, you can do the Yamane also. I tend to use the glued IOL, which gives me much extra stability, but you can do whichever technique which you are comfortable in. Once you have done that, all you need to do is create the Gabor-Chariot's pocket. Great thing started by Gabor, great surgeon and a great human being from Germany. Create the Gabor-Chariot's pocket with a 26 gauge needle, tuck them inside. Now see, is your pupil good enough or not? If it is good enough, no problem. If it is not, always do a 4th row pupiloplasty. Here you see I'm just bringing this pupil down. In this particular case, I've injected triamcinolone. Check if there's any vitreous present there. If there is, it will all be seen very clearly. In this case, I didn't do a pupiloplasty because I felt it was not needed. The pupil came down, and I completed this case by putting the fibrin glue inside and sealing everything down. And you can see that in this case, the fibrin glue sealing everything down. So this is taking the difficulty to the slightly next level, because in the first case I showed you the IOL in the sulcus, the second how the glued IOL is working after the IOL scaffold. Now look at this case. Patient had a multifocal IOL. There was a refractive surprise. I had to exchange the IOL. So what we did was, you saw the HOA here is quite high. The normal is 0.3. Now this is a toric multifocal IOL. So I'm bringing this IOL anteriorly. We published this first with Dr. Priya Narang, Roger Steinhardt, and Brian Little in the JCRS, where we are using the IOL scaffold for IOL exchange. The advantage is my IOL has gone behind the lens which I'm going to remove. So when I cut this IOL, I don't have any fear of cutting that IOL or cutting the posterior capsule by mistake. So I can explant it. In this particular case, once this was done, I did a pinhole pupiloplasty, but that's a different story. Now look at another case here. Surgeon had operated, left the IOL inside, which is the one piece, left a nucleus inside, and there was also bullous keratopathy. So I brought the nucleus above the existing IOL and used it as a scaffold. Now my problem was to remove this IOL. Now if I just cut it and remove it, the chance of the IOL falling down is there. So what I did was, I did a glued IOL because I don't have any support. So I'm doing the glued IOL behind the existing IOL. Done the handshake technique, tucked it inside. Now you see you have created your own posterior capsule. So in other words, ladies and gentlemen, this is the glued IOL scaffold we are doing for IOL exchange. Once that's done, I can then treat the remaining area. Now look at this case. In this case, the patient has microcornea and also got Sommering ring. Now remember, if I have to just remove a Sommering ring in eyes in which there is no capsule, it is going to be very tough. One, they will not come out easily with vitrectomy probe. So what I'm going to do, I have to do a glued IOL. Why? Because there is no capsule. The iris is above the Sommering ring. I need to go behind the Sommering ring. Either I have to do a Yamane IOL scaffold or a glued IOL scaffold, and we published this in the year 2015 in the JCRS to manage Sommering ring. We broke the additions, bring the Sommering rings to the center, and before you can say bingo again, those Sommering rings can be emulsified. Coming back to this particular case, you see, I'm implanting the IOL behind the Sommering ring. It's a microcornea, so I just cut a bit of the haptic. Now enlarge the pupil with iris hooks, break those additions with the periphery and the Sommering ring, bring them to the center. Now I can very easily emulsify these Sommering rings without any fear of them falling down. So the way you manage Sommering rings, in my opinion, is this would be the best way to remove Sommering rings in which there is no capsule, because you have, if these fall down, it's a headache to remove. They cannot come out so easily because they're quite thick. And that's one problem with these Sommering rings. Once that's done, take out the iris hooks and complete this particular case. See the patient 1 week post-op. Now let's take a traumatic case. Can I use IOL scaffold in this? We published this also. Look at this. Vitreous hemorrhage is there. The patient had an injury, intraocular foreign body. It's a large foreign body. Now what we have done is, we have brought this foreign body anteriorly. Now look what the problem is. When I want to remove this foreign body, it's starting to sink. So now I thought, let me do an IOL scaffold for intraocular foreign body. So I'm putting a 3-piece IOL into the sulcus, since I have a good sulcus here. Once I have done that, now my fear of this foreign body falling down back again is not there. So I'm using my handshake technique, you can see here, transferring it from one hand to the other, and I can very comfortably remove the foreign body. So this is an IOL scaffold showing you for an intraocular foreign body. And look at this last case. This patient had a sublux traumatic cataract. Now in this case, what am I going to do? Rather than emulsifying that straight away, I will first do the glued IOL. There's no capsule support worth the name. So I'm going to do the glued IOL behind the sublux cataract. Once that's done and the haptic tucked into the Chariot's pocket, Now I can very comfortably bring this cataract to the center and emulsify it with a phaco probe without any fear of the piece falling down. And you can see how the case looks when it's completed. This is just to show you the photopuplasty, because in this case, traumatic case, there was a traumatic mydriasis also present. Complete it as many times as you want. The advantage of photo is a very simple technique. Seal everything down, complete the case, and this is how the case looks 10 days post-op. Vision is 20/30. So ladies and gentlemen, we have shown you various scenarios of IOL scaffold, and I'd like to thank the ESCRS team, APAO, and AIOS for this lovely symposium. Thank you very much.
Thank you. Thank you very much. Thank you very much to all the speakers. And now we have time for discussion, which I think will be also very interesting and maybe the most... Amar, you can come and sit here. Yeah. I think that you have lots of questions. Maybe one comment and something that we didn't say up till now is that those who are not familiar to repair the anterior segment of the eye, the best thing that you can do is close the eye and refer, because otherwise you may lose the eye. You know, prolonged surgery, very low intraocular pressure may trigger suprachoroidal hemorrhages and then explosive hemorrhages. So I think to avoid that, please don't go too far. Know your limits and send to a center that is that knows quite well how to deal with.
Yeah, Dick, you are a posterior segment surgeon, and I think most of us out here are anterior segment surgeons. So middle segment surgeons is what we are talking about nowadays when we should be, expanding our horizons, the anterior segment surgeons. You showed it so nicely, so beautifully. What all tricks would you, and what all precautions, and what is the way for an anterior segment surgeon to move on to become a middle segment surgeon for handling what you said, the posterior vitrectomy and everything?
Yeah, thank you. I think the steps are easy, to be honest, because it is, there are so many diagnoses where you can step backwards, because we are doing already intravitreal injections as anterior segment surgeons. And so my recommendation would start with diagnostic probes, for example, or core pars plana vitrectomies to make yourself comfortable with the settings and the devices. And then there's the complication, that's then an easy step forward to manage this too from the posterior aspect.
We also, I think that's a very good approach. Burkhard just pointed out, core pars plana vitrectomy is really a good step into this. It's even good for the posterior segment surgeons to start with, because it's an easy one where you basically remove some central vitreous, for example, floaters, or if you want to put some medication into the eye. So that's a good approach. But one thing what we should point out is here, the anterior segment surgeon should not try to get the posterior pieces or the pieces from the vitreous with a phaco probe, because if you do this, then you risk a lot of retinal detachment problems, and you have to vitrectomy and not taking the probe, the ultrasound probe, to go behind these pieces. Very important.
I would also like to address another point. In fact, registries are very important, and Rohit and Amar, I'm not sure whether you are starting registries here in India, because, for example, the incidence of posterior capsule rupture has been studied by the RECO registry at the ESCRS, and you see a beautifully down gaze of the incidence of the posterior capsule rupture. So I think that is very important. Now at the Eureco, we are about 1% of incidence of rupture. So that means that indeed the techniques are better understood, that people knows now better how to handle it, and I think that I cannot insist enough on the importance of registries, and I think that is what I also wanted to address on.
Yeah, I think we do not have it as such as of now, but definitely going ahead, this should be incorporated, and I think AIOS should take a stand on it and involve surgeons right across, because there's so many the documentation right in the peripheries.
Yeah,
is-
of course, I know it is not easy.
Yeah, and with such
Yeah.
a massive inflow of patients, wherein I know surgeons who are doing more than 60 in a day, and they
Yeah.
are
Yeah.
and
Yeah.
they don't have anything else.
No time
you don't-
to write down and to sit
But
down.
it
so
should
you need
definitely be done, because as ESCRS has shown how the registry, because that puts in a lot of thought process, and that would eventually improve patient outcomes in the long run.
in the long
Definitely.
run. Yeah.
Dr. Amar, you would like to add something?
Registries in India.
Oh, yeah, it's a very good thing. See, we have a clinical board. For example, since we have got huge number of 240 hospitals across India and Africa in 10 countries, the problem is, suppose someone has it, we have a clinical board there in which we even have foreigners like Nicole Fram and Jodh Mehta. So any PCR or anything happening in any of these centers, let's say in Mozambique if it's happening, it has to be reported to the board. So the advantage is we are able to standardize it. If you have one center with, let's say, one surgeon operating, it's comparatively easy. But when we have 750 doctors with us right now, it becomes very difficult to monitor. So I think it's very important when we have complications will happen in any center. But the idea is to centralize it and see that adverse events are reported. So for us, registration of these complications are extremely important.
What I think is also important is what Rohit shows. A posterior capsule tear doesn't mean necessarily that the anterior hyaloid is also broken or destroyed. And that you have to recognize, because then you can save really the eye very beautifully, and it's just like if nothing happened. And you beautifully showed that.
Yeah, I
Thank
think,
you.
the low fluidics have really helped with stable chamber settings in these patients. And posterior capsule rupture doesn't mean that the anterior hyaloid phase has broken. So unless you have really, hit the probe with you have not been very, cautious about it. You have to realize that that anterior hyaloid phase can eventually help you. It acts as an ally rather than a foe. And if you meticulously do with stable chamber settings and with all the anterior hyaloid phase friendly settings, it can be, you can wade your way through the difficult posterior capsule rupture.
Absolutely. I think also the presentation of Vladimir Pfeiffer is of course excellent, and as always. And I would also like to address that there are different approaches for lens luxations. Even there are different degrees of lens luxation or dislocation of the lenses. So each degree of dislocation might need another approach, or do you always use the same approach?
It is true. In late 90s, we did some children, about 12 children, and implanted the capsular tension rings. And after 10 years, everybody dislocated.
Yeah.
So we had to go for the second surgery. Maybe if we would do 2 fixation, it would be better. So because of that, I do prefer, now that Yamane is there, scleral fixation. We have follow-up of 7-8 years now with the children. It's still safe. We didn't have major complications.
Yeah.
So another thing what I would like to emphasize is the hydration of the vitreous. If we don't hydrate the vitreous, then we have much less trouble with the vitreous, and we can push it backwards. Even if doing a vitrectomy, if we don't hydrate when doing the vitrectomy, just the vitrectomy, get a little bit hypotony and then push in viscoelastic, then we will manage vitreous much easier. When we hydrate it, it will come forward and forward.
Yeah, absolutely. That is in fact a very important remark that you made. Unfortunately, we cannot measure preoperatively the degree of liquefaction of our vitreous. Would be an important parameter though, because you are right, in a very liquefied vitreous, the vitreous, whoops, goes out and very easily, much more easily. Unfortunately, we cannot follow it, but you see it, and that is because that is maybe also one of the factors why we have features prolapse and important features. But we know with aging that there is a big liquefaction. We know that we have syndromic conditions where you have a high liquefaction of the features, high myopia, high liquefaction of the features. That's the one we know, but there must be some other parameters, but that we don't know yet. Yes, please.
Thomas, I have a question to you. You pointed out the second eye dilemma. When the first eye was operated very successfully, patient happy with a multifocal IOL, and then you have a PC rupture. What is your personal strategy if you cannot implant the one-piece IOL into the sulcus as well, or you don't want in Germany at least because of legal issues, and also cannot implant it into the back? Are you implanting a monofocal and go for add-on technology, or what is your approach?
Well, I think, as I pointed out, this is a really dilemma at the moment, and I would, if I really cannot put the lens into if I cannot do anything, because we have only these lenses which have sharp edges, you put them in the sulcus, and many people do this, and then you have pigment dispersion later and you have glaucoma. That's not a good solution. So I would then go for any type of capsular bag monofocal lens implant and add an add-on technology if the patient wants to have that. That's a way out. The other thing we were just together with Shariat in Trieste just the other week, and he demonstrated how to implant a multifocal lens with his technique, which is also a difficult way to do, but a way out maybe to take, POC or an Odyssey or Panoptics into sclerofixation. So that's a new thing we should look at, but we really stuck there because we don't have the support here from the industry. They don't provide us with the three-piece IOLs in the sulcus. Unfortunately, there are not too many cases, so the industry has not too much to gain here, but we need it.
You're absolutely correct. There is a demand, there is an unmet need there, but the volume is often the problem for the industry. Yeah.
So then I have another question to Vladimir in terms of the choice of the needle for the Yamani technique, because I've seen several papers that there are production differences in terms of the inner lumen, and often they had problems in getting the haptic in.
Yes, it was my thinking also when I started the technique, because I was not able to get it in, but actually this is my fault. I didn't measure it. There was a study measuring these openings, but now then I used to try outside of the eye if it goes in or not. But now, after I'm much more experienced, I can duck every haptic into this needle, and I think MTS, I don't know what are the needles. Therefore, what I'm using are Sterimedics needles, and they are very good.
So Amma, what are you doing to really prevent an old Semmering ring going to the back? Because if it's in the back, it's a tough time because they're sometimes very hard, they're calcified, and it's hard to get them out. So what are your pearls for an anterior surgeon to not let it down beyond scaffold technique?
If there is no capsule, the only solution is, in my opinion, to do a scaffold. Because there's no other way you can do it. Because if there's no capsule, I need to go behind the Sommering ring. And the way I can go behind the Sommering ring is, where will I keep my IOL? I need some support. The only way it can be done is either through a glued or a Yamane technique. Once that is there, then you can bring the Sommering ring into the center. You can do, with luck, you can try to burp it out, or use a Sufekchi, use a cartridge. But all these techniques need, in my opinion, first a posterior capsule. So the scaffold, I think, is the only opinion I can think of. I can't think of any other treatment in these cases when there is no capsule I'm talking about.
So thank you very much, all the faculty members. I think we are absolutely well on time, perfectly well on time even. And it was a really beautiful session, if I can say it myself. And thank you for the APAO for having invited us and for being here. Thank you.
That's good.